Hello, welcome back to Neurospicy Nursing. For this lecture in the exam, like final review series that I've been doing for you guys, this will be all of the neuro, HEENT, all of that. So um, there's a lot of information to go over. I will try to make it as short as possible. I don't want to like bombard you guys with all the studying that you're doing and giving you like a 2 hour lecture. Um, so I may end up breaking this into two parts, like uploading like the first hour or something if it ends up being that long, and then cutting the video at a certain point, and coming in with editor Celine and then say, hey, I'm ending it here. Go watch part two for the rest of the information. But that's in the event that you're seeing this and it's only like it cuts out in a weird place. There may be a part two. I'm not sure yet. Um, but yeah, this lecture is all HEENT in a row. We're going to cover the autonomic nervous system, those medications in this lecture as well. We're also going to go over our positioning that we see, the digicorticate, decelerate, migraines, cranial nerve stuff, and like Glasgow Coma Scale, Stroke Scale, all of that is going to be covered here. All right, so this is just the general, it's very similar to your general survey. For HEENT, where you're gonna inspect them first. You're gonna look at them. You're making sure, are they having a facial droop? Do they have, just looking at their eyes, do they have one pinpoint pupil, one blown out pupil, are their ears at normal level, or is one like not there? That's what things that we're looking for that. That's just the general inspection. Um, Looking, inspecting, you're looking for the skull shape. Is it round? Is it, relatively symmetrical, right? Everyone's face is not distinctly symmetrical. Most of us are non-symmetrical, and that's normal. But again, if it's very distinct, like you have one ear that's in a normal level, and then the other one's pulled towards their jaw, that's something to look at. If they have any noticeable uh, like lumps or anything like that, like if you're looking at their neck and you can see like very visible like lymph nodes there, that's going to be something to worry about. But then, when we're um, typing this up, we should make sure that if there are any abnormal things like those lumps, those bumps, um, any bruising or anything like that, um, the facial drooping, that it's properly documented, one, and two, based on those things, we're going to ask follow-up questions. We're going to ask, if they have any bruising, like, did you fall? Like, what happened, And then if, let's say, in the event it's a more domestic related issue, you're going to separate the two candidates, right? And then you're gonna see if you can get a story from both of them. And based on how the bruising is, you're gonna be able to tell, right? Someone's gonna say something and it looks more accurate to how the bruising is versus the other individual. All right, so pupils. So pupils are super important because they can tell us a lot of things, right? A blown out pupil is very indicative of some sort of neurological injury, or a unilateral, like two different pupil sizes are also indicative of some sort of neurological injury. The other thing is if someone has, let's say, pinpoint pupils, right? We're going to be worried about opiates, stuff like that. Um, Especially if they're like non-reactive and pinpoint. That's a pretty good indication of some sort of opiate overdose, overuse. Um, so looking at our pupils, right? They should be equal, round, reactive to light and accommodation. Looking at the pupil sizes, about 3 to 5 mm's is normal. Obviously, people who have light colored eyes, as in like blue, green, stuff like that, they'll have bigger sized pupils because their eyes are just way more sensitive to light. And again, that's going to be more normal to them. Um, but the iris of the eye, take note of any sort of like heterochromia type things, like if their eye is almost like split with like half brown, half blue. You do have to monitor some of those because they can obviously get bigger, right? Um, and then our conjunctiva, so that's that pink mucous membrane. When we like pull down our lower eyelid, that obviously should be pink. And then our sclera should be white, right? Um, Things that we're not expecting. So any bulging eyes like we see in some thyroid disorders, there's something called strabismus. Strabismus. I always want to say strabismus. I don't know why, but that's your lazy eye. So that is normal in little kids, but after a certain point, it should have rectified itself. And then if it doesn't, that's cause for concern, right? They may need special type of glasses to help correct that or some sort of surgical intervention. Some individuals who have strabismus actually are kind of blind from it. Um, so that's another thing to keep in mind. Any redness, anything like that, discoloration, all things that you're not expecting. So, talking about the ears and the nose. Um, when we are visualizing the ears, specifically in the like to look at the tympanic membrane, for adults, we usually pull up, like up and back. And then for children, we go like down, down and back. So think of it like, oh, your older kids, you're telling them to get up. Your younger kids, you're telling them to sit down because get up, get up, go do your dishes, sit down, quit fooling around, something like that. Um, it's easier for some people to help correlate it that way. All right. Other things that we are expecting to see is the presence of earwax. Remember, there's two different types of earwax. There's the hard one, and then there's the um, more wet, sticky one. Um, Individuals who have really, really hard earwax, they have the tendency to have to go into like ENT or go to their PCP and almost get that kind of like flushed out with like something that looks like a water flosser just to pull out that extra earwax. Um, but the tympanic, going back to tympanic membrane, sorry. When you do look at that, please remember that it is supposed to be a silver color, and there should be no fluid in front of it or behind it, right? That fluid is indicative of that otitis media. So we don't want anything behind it, those ear infections, right? And then if it's red and kind of inflamed looking, again, we're thinking of those ear infections. So with our nose and sinuses, we have sinuses, we have maxillary sinuses, we have I don't know what the ones in your forehead are called, honestly. I just know maxillary sinuses, which are in your cheeks. Off the top of my head, I'm so sorry. But for individuals who have chronic nosebleeds, Afrin can actually be used to help constrict the blood vessels. Do note that Afrin is actually something that um, can be and has been abused by people. Um, so also keep that in mind uh, when you are recommending Afrin or you maybe notice an individual exhibiting signs of overusing Afrin. There is also allergic rhinitis. So rhinitis is like, that runny nose, right? Um, you can get this when you have allergic reactions or when you're sick and stuff like that. Um, and then sinusitis, that's that infection in the sinuses. So for our mouth and throat, we should have no redness, no tonsil stones, no ulcers, no anything, right? Everything should be pink. We shouldn't have a beefy tongue. Beefy tongue we talked about is indicative of the um, B12 deficiency. And then oral thrush, we talked a little bit about it for musculoskeletal. We know when we're taking those steroids, it causes that immunosuppression, and so it'll look almost like milk, right? But when you go and you look at it, like really look at it, and you try to scrape it off or rub it off or anything like that, it may look like milk. It's literally that it's the exact same color, has the same type of coating as, when you, like, if you were to stick your tongue in milk, but it's not going to come off. So, certain steroidal inhalers, epileptic medications, as well as those DMARDs, TNF agonists, or sorry, antagonists. They all have the risk for your mouth to either have like chronic gingivitis or chronic uh, cavities or just a lot of teeth and mouth issues, oral thrush, stuff like that. So just keep also the medications that they take in mind when you're doing their oral assessment because there are medications that put them at higher risk. Um, so looking at the neck, so I talked a little bit about it, no, you should be able to feel the lymph nodes, right? Like you can feel them a wee bit, but they shouldn't be extensive. If your patient is having a lot of pain moving their neck around or like can't lift their neck up at all, um, you're worried about meningitis in this case. So that stiffness, it's going to be very different from like morning stiffness and RA. It's like they physically can't move. It causes them like an obscene amount of pain. Um, Other things like tracheal deviation, stuff like that, we're not expecting to see that again. Dysphagia, or like any dysphagia, any um aphasia, anything like that throughout the HEENT assessment is not normal. So for the neuro exam, just HEENT in general, we are, well, less HEENT, but for the actual neuro exam, we're expecting the brain, spinal cord, and all of that to be included in this exam, like when we're, actually going through it. If you're doing a full neuro assessment, it's normal, not normal, but if you're worried about certain things, you will do like a cranial nerve assessment or a spinal assessment. Like if you're worried, they just had a car accident and they're saying like I can't feel my legs, I can't feel my legs. You're gonna be worried about some sort of spinal nerve damage, right? So for your mental status, you need to make sure that you get a baseline and then you're gonna compare that baseline to any future assessments that you do while they're there. So, you know, I commonly like to ask, tell me your name, tell me your date of birth, what is today's date, who's the current president, just so that I can get a full understanding of, like, do they know what year we're in? Do they know what's going around them? Do they know why they're here? To get an understanding of like how oriented they are. For memory, you can give them like 3 words to remember and then wait a few minutes and then, you know, ask them again and then wait a few more minutes and then ask them again. Um, or um, attention and concentration. Um, that kind of goes along with memory as well, where if I wait like 10 more minutes, are they still going to remember? Because that has some ability of concentration. And then attention, I think of that more as, when I'm trying to have them do something, are they even paying attention? Like, if it sounds silly to say attend, like to assess their attention, are they paying attention? But some people might not even realize that they're completely zoning out. And sometimes full zoning out it could be like types of epilepsy, right? Like those absent seizures. They may look like they're listening, they're not saying anything, and they look a little zoned out, but that could be something actually neurologically wrong with them. They're actively having a seizure. So that's another thing to keep in mind. And then language and speech, give them a few words to say. And then, are they slurring their words? Are their words making any sense, or are they jumbled? So going into the cranial nerves, I'm not going to go too in depth, but please do remember that the eyes have four different cranial nerves that are associated with it. Um, all of the big highlights of kind of like how you would test for these, and as well as what nerve it is, the name of the nerve is going to be on the slides for you guys. Um, so I'm not going to go super duper in depth. But the eyes have four, and then your kind of tongue, mouth, gag reflex stuff that has three. So that's another thing to know. Um, this one down here where it says the highest suicide risk of any neuro disorder, I guess it was supposed to say clinical pearl and then a dash next to it. That's specifically talking about trigeminal neuralgia. Um, Again, if you're one of my students, you've heard about trigeminal neuralgia before. I tend to talk about it a lot. I'm not going to go super in depth with it right now, but if you know, you know. Okay, so motor function and sensory function. So for all of these tests, we have like our proprioception test, the Romberg tests, and these are just to evaluate the actual functionality of the motor and sensory nerves in an individual, right? Individuals who have let's say they just had a stroke, they might shuffle because of unilateral weaknesses. Or if they have cerebral palsy, they might have some sort of ataxia. Um, those are going to be that's that patient's baseline. Those are, well, technically not if they just had a stroke, now they have unilateral weakness. But in the case of the cerebral palsy patient, ataxia is their norm, right? So, um, you would document that, as their baseline. This is going into deep tendon reflexes. Please remember that people who take magnesium, IV magnesium, normally they'll start with like Qantas and a +4 DTR, but you have to make sure that if their DTRs become absent, that we're giving them the reversal agent, which is calcium gluconate. Also, if we see any of the um, kind of innate slash, biological motor reflexes like Babinski sign. Um, when we're assessing our patient, we're worried about a neurological injury because this sign, this Babinski sign, it's usually gone by like it should fully be gone by like 2 years old. So an adult having this would be abnormal. All right, so this is talking about Glasgow Coma Scale and the Stroke Scale. So Glasgow Coma Scale, it is obviously measuring an individual's level of consciousness. So the motor response is going to be from 0 to 6, the verbal response is 0 to 5, and then the eye-opening response is 0 to 4. And then based on what they score in each section, you're going to add them all up, and that's how you get your score range. So a deep coma slash brain death is really anything below 3. Obviously, they'll do an EEG to rule out whether or not it's brain death or an actual coma, have some sort of brain activity if it's a deep coma. Versus 15 is going to be completely awake. If you do your GCS and an hour later, the GCS has lowered. obviously that's going to be, if it's especially if it's lowered significantly, right? We're going to want to make sure that we establish that patient's airway because now they're at risk um, for not being able to breathe properly, right? Their brain's not functioning. And then you're also going to make sure that you have the provider come and assess them as well. Um, Most likely, they'll probably get like an EEG or something like that to kind of look at the brain or maybe some sort of scans before provider will come in and kind of do their assessment. But that's just something to keep in mind. And then we have our stroke scale. So it goes all the way from 0 to 42. It's a huge range. Um, but um, you know, the level of consciousness is included in that. And then we have some other things with the NIH Stroke Scale. Um, like you're going to give them that photo that they're going to be able to describe, or you'll give them a set of words that have nothing to do with each other. And that kind of tells you how their brain is working. Um, do note that they're at least at, you know, our hospitals, for those who know me in person, um, these are done by qualified and trained stroke nurses or providers. So you have to be trained in order to really use the NIH stroke scale. So I won't go like fully in depth into kind of what it is, but these are just some key points about about what it is. All right, so here's a little bit of a case study. I'll give you guys a few seconds to just kind of look at it. So, this patient, they have dysphonia, that raspy voice, me the other day, when I had recorded like three of these back to back because I kept making mistakes. Um, but also they have dysphagia, which is the difficulty swallowing and stuff like that. So those are going to be the cranial nerves that are going to be involved, which is glossopharyngeal and the vagus nerves. Um, because of the dysphagia dysphonia, we're going to be worried about a stroke. So we're going to go ahead and initiate, in this case, it would be initiating code stroke, getting the CTs or MRIs or whatever it is that they need, and then doing the rest of the NIH stroke scale. Um, After kind of all of that's done, they'll do a bedside swallow to see, how bad is the difficulty swallowing, or like, do they just need thickened liquids? Do we need to put an NG tube in them because they're at such high risk for aspiration? That's what bedside swallow is going to help do. Okay, so don't forget, make sure you're also telling your patients to do preventive things. you know, Go to your hearing screens. Don't listen to loud stuff all the time. Um, or like if it is loud, don't be in such an enclosed space or have it right on top of your ears, like in headphones and stuff like that. Make sure that you're flossing your teeth, brushing your teeth, seeing your dentist. Make sure that you're seeing your eye doctor as well. These are all very, very important. Or don't be like me, where they used to teach me when I was a swimmer to put alcohol or hydrogen peroxide in my ear to remove water after swimming. All right, into the next section of this lecture. It is going to be going over the actual neurological assessment. Um, so again, we are, you know, either establishing their baseline, or if we do know the patient, we know their baseline, using this assessment to kind of see whether or not we need some sort of life-saving intervention, right? So if a patient complains of headache, dizziness, numbness, changes in memory, changes in their ability to hear, and they have a past medical history of any of those things, we're going to want to do a focused neuro assessment at some point to make sure that there's not anything new popping up. So with mental status, I talked a little bit about it. We have to make sure that we're orienting the patient. Can they stay focused on what I'm saying, or are they, like me when I don't take my Adderall and I'm bouncing all over the place. Um, but again, that attention portion, that's going to be important if you're actually, you notice that this person can't stay focused. Maybe they do have ADHD. Maybe they do need to be on medication. Um, for the memory testing, um, that's also important because if someone just had a stroke, and it was in a certain part of the area, a certain part of the brain that's responsible for their short-term memory, has that now been impacted? Is that now affected? Um, so that's why we ask these types of questions. Same thing with language and speech, right? But the thing to remember about this one is that, um, you know, it's obviously not just about slurred speech, right? One of the big things with the language and speech portion is with some people, they kind of stumble over their words. I do it. It can depend on the medication they take too. But if you know your patient and you know that they don't, you know, normally fumble over their words like they are right now, or let's say you hear them talking like they were talking just fine, and then a few minutes later you're talking to them and nothing that they're saying is making sense, and you're listening to them and the sounds that they're making aren't like word sounds, that's another thing that you need to keep in mind. Okay, so again, one of the biggest things, and this goes along with our culture care, just because someone doesn't speak English doesn't mean that they are non-compliant, using like air quotations that you guys can't see, but doesn't mean that they're non-compliant and doesn't mean that they are any sort of like cognitively or mentally altered, right? We have to make sure that we're using qualified interpreters to get the point across, um, because you want to make sure that they're understanding the risk. Okay, going into hidden risk, again, I'm not going to go into a lot of trigeminal neuralgia, but it does have one of the highest suicide rates of any neurological disorder. Um, so make sure that you're vigilant on these individuals' mental states. Um, they have chronic pain, and it may not always be covered with just an anticonvulsant medication. Some of them may have to be put on anti-anxiety medications or antidepressant medications also. Oops, oops. Okay, so here's those cranial nerves. Again, this is for the assessment portion. Um, I talked about, or on here, I have some of the, you know, actual functions of the nerves, um, and the way that you would assess the nerves. It was on the last slide, but since this one's more based on the assessment of like the nerves and stuff like that. Do note, I want you guys to make sure that um, for the hypoglossal, um, if the tongue is not crossing the midline, that's a red flag, right? Because if something's in the midline of your body, it should be able to move left and right. Um, it's not going to be like, your eye where you can blink one eye and not blink the other. If it won't cross the midline, there is a neurological issue that is happening. Other things that we're going to do here, very similarly to kind of our musculoskeletal assessment, is we're going to document their muscle strength, right? So are their left upper extremity and right upper extremity the same? Are their left lower extremity and left or right lower extremity the same? Um, some conditions, like I talked about how cerebral palsy, they have rigidity. That's another thing to keep in mind. Some conditions like CMT, they have flaccidity. More commonly for those patients, it's just going to be in their limbs, especially if they have like the more rarer kind of CMT. Those patients are usually going to be wheelchair bound and they have lost the functions of their um, legs and arms. Their trunk still works, but it's just their legs and arms, or um, If you guys have ever heard of Gypsy Rose Blanchard, unfortunately, she made um, muscular dystrophy uh, very well known. So they also have flaccidity in their muscles. We're also going to test for coordination. Some individuals may be, again, ataxic, or they may have being it have issues being able to tell the depth of something or how close or far away they are from something. Um, the coordination test is going to help, identify that. Um, you know, finger to nose, heel to shin. Is a little bit harder. I've never really seen that one, but that's obviously going to be harder to do. And then abnormalities, we talked about the ataxia, the shuffling, stuff like that. And then proprioception, that's when you're kind of sitting there and you let yourself stand there. And you're trying to see if kind of like your body can kind of stay in the same position it was when you close your eyes. All right. So to assess our sensory functions, we're going to use the light touch. This is when we take like a cotton ball or the tip of a Q-tip, and we're just kind of placing it against our patient's skin, and we're saying, does this feel soft or sharp? So then we'll do the soft thing. And then we'll change it to like maybe the more blunt end of the um, Q-tip, and we'll ask them the same question. And we do it on different sides of the body. We're going to compare the right side to the left side because we want to be able to know whether or not they can actually sense, is it sharp or is it soft? Also, um, we can do the vibration sense, especially, like kind of right in front of the ear. That's a good way to see if they have like conduction issues with their hearing. All right, deep tendon reflexes, kind of going back into them. Um, Remember, it's a scale from 0 to 4. There are reflex movements that are completely normal, and are actually commonly seen in brain death. A patient, could be brain dead, and you may think they're holding your hand, and they're not. So it's really important with the reflexes, that you also let your patient's family know, like you don't want to give them false hope, especially in the event of a severe brain injury. If they are fully brain dead, um, I don't want to say that you're going to brush them off, but maybe just kind of educating them that, it's normal for these individuals to have a reflex of, if you put something in their hand, they're going to grasp at it, right? That's that grasp reflex, um, that babies have. Um, all of those initial reflexes that you're born with, they kind of come back when you have these really, really severe brain injuries. The other thing to keep in mind is clonus, which is that rapid kind of jerking of your foot. Um, I like to think of clonus very similarly to tonic-clonic, because it's kind of that same jerking type motion, but one's just in a seizure versus one is, you know, it could it's it could be from the decrease of magnesium in someone's bloodstream, right? And then also know that there are a ton of different deep tendon reflexes. Um, the most common one that you're going to see, and you've probably had it done to you before, is going to be at your knee, where they take that triangular little thing that they hit your knee with at the doctor's office. That's what we mean by deep tendon reflexes. Okay, so for um, pupil responses. So a 6 to a 7 doesn't necessarily mean sluggish, by the way, but we got blown out pupil, brain damage, stuff like that. It's going to be those really, really large pupils. Very constricted. I talked a little bit about before. We're worried about um, opiate overdose with that. Um, and then again, a normal pupil is going to be about 3 to 5. All right. So our Glasgow Coma Scale, again, this is measuring level of consciousness. Um, there are like five full categories of a level of consciousness from like, normal, lethargic, there's obtunded, stuporous, and there's one more. But that's what we mean by when we say level of consciousness, is we're specifically also talking about those as well. It's not just, I mean, most times, if someone's obtunded, they will have a little bit of a lower Glasgow Coma Scale, but those are other words that you might see in correlation with level of consciousness. And then we have the mini state mental examination. So this is going to be more for, um, assessing the memory of the patient. But it's a cognitive test. A lot of times I feel like a little bit older patients kind of get it. But yeah, we're going to assess their cognitive function, their ability to um, memorize things, their attention to detail, and how are they perceiving language. So here's a little bit more in depth about what the stroke scale is, and then some stuff that's assessed during it. So there's about 10 different sections. I've listed 9 because I kind of put best gaze and visual fields in the same section. I'll explain why. But so we're talking about the NIH Stroke Scale. So again, it's assessing the actual severity of the stroke. The lower the number, the less severe, the less kind of complications that they're going to have because of their stroke. Also, don't forget that there's 2 different types of strokes. There's an ischemic stroke, so the lack of blood flow to an area, and then there is a hemorrhagic stroke, which is a brain bleed. Okay, so with the components, level of consciousness, so going back to the Glasgow Coma Scale, best gaze and visual fields. So, are they perla? Can they do all, when we say accommodation, are they able to move their eyes side to side, up and down, and diagonally? That's really what we mean by visual field. There's 6 visual fields. Facial palsy, so drooping, or is it like really stiff? Motor leg function, I talked about that unilateral weakness. Coordination, same thing. It deals with that unilateral weakness. Can they even lift up their arm, or is it just completely needs to stay at their side at this point? Language abilities, so the aphasia, there's multiple different types of aphasia. Clarity, that's with, speech clarity, and are things important to them, understandable to them as well. And then extinction and intention goes along with the motor function and ataxia, like when you have that unilateral weakness, do they even understand at this point that that R is kind of there, like their brain almost ignores it. And if they were right-handed, and let's say they have a left-handed stroke, because remember, your strokes are going to happen on the opposite side of where the weakness was. So again, let's say they had their right-handed left-sided stroke, and you see them start trying to write or pick things up with their left hand when they know that they're right-handed. That's extinction and inattention. So this is just the stroke scale again, in just a little bit more of a colorful way. All right, so abnormal findings that we're going to see throughout the neuro assessment, so cognitive, motor, sensory, coordination, our reflexes, and then our gag reflexes, or well, reflexes and then our gags. Multiple different types of gags, speech tests for that. You're not going to need to know the left, right, up, down. I don't even know all the gags. That's a speech therapy consult thing. Speech therapy does your swallow consult as well. So make sure that you keep that in mind. Okay, so that is done with the um, kind of neurological HEENT assessment portions of things. Um, we're gonna move into um, the actual more pathophysiological pieces of this lecture. Okay, so this one's specifically going to cover the central nervous system. So our central nervous system, it's our brain, it's our spinal cord. This goes over, what kind of each of the nerves in certain areas are responsible for when we're talking about our spinal cord. Um, so T2 through T12, that's our trunk, right? L2, L5, our legs. So someone who had a L3 injury, they might have issues with their legs, right? So that's what we mean. Like if a paraplegic came up to you and they were like, "Oh yeah," if you asked them about it, they said, "Oh yeah, I have an L3 injury." Well, the injury to their L3 is what caused that paralysis. I hope that makes sense. Um, And then this is just some basic anatomy of your brain. We have our frontal lobe, parietal lobe, occipital lobe, and temporal lobe. So those are the four main lobes. We also have our brain stem. This is all of our basic life functions. Um, and this is where, and when we talk about that Glasgow Coma Scale, and I believe I'm going to talk more in depth about it later, um, the compression of the brain in this area is what's going to cause that disseparate positioning. Okay, so this is an actual in-depth of the Glasgow Coma Scale. Again, I just talked about the decorticate decelerate. So motor response is 1 through 6. So abnormal flexion, that's that decorticate positioning. So they have their elbows flexed inwards towards their chest. And this is going to be injury to their cortex. So corticate cortex versus the abnormal flexion is going to be for the separate positioning. So their arms are straight, their legs are straight, and this is injury to our brainstem. Um, a lot of times, this separate positioning can be seen with like increased intracranial pressure, um, kind of along with something called Cushing's triad that you guys are not going to need to know. But that is separate positioning, again, compression on the brainstem from whether it's, tumors, increased intracranial pressure, anything like that. Um, and then that's going to cause, um, or not cause, but it's an indication that someone's brain could be herniating. So here's a more kind of in-depth photo. Decorticate positioning, arms are flexed. Again, location of the damage is anything really above the brainstem, so anything in the cortex. It's great. It's pretty severe. It's pretty grave. But again, it's not more severe than the decelerate posturing, which is this individual is very stiff. This is the brainstem that's injured. Um, and they have a much worse prognosis, and there could be a good chance that they're not gonna do well. So, a little bit more about the stroke scale. Um, the one thing that I did want to note, I talked about, the stroke units and the stroke nurses, but I wanted you guys to know about the fact that since it's a scale from 0 to 42, 0 does not mean that someone does not have a stroke. 0 just means that they don't see or foresee this individual having any neurological deficits, but imaging has confirmed that a stroke is going to happen, but either based on the area or because it was caught quickly, they think that this individual will have no neurological deficits. Here's a more visual photo of kind of what I was talking about with the NIH Stroke Scale. Again, level of consciousness is going to correlate with GCS. Best gaze, their ability to track, visual fields, can they even see? I think I flipped those around before, but can they even see you, or are things blurry? You're gonna have them cover one eye. Can they see with it? Cover the other eye. Can they see? Um, Sometimes depending on the location of the stroke, it can, um, cause damage, lead to blindness. So it's another thing to keep in mind. So facial droop, ask them to smile. That's going to look at that facial nerve to see if that one has been impacted at all. Not just with the stroke scale, but if you have any inclination that the facial nerve has been affected, we're going to have them smile and see. But it's very common for that be fast acronym that they use for strokes. We'll have them smile and see if they have any facial drooping. Okay, so um, I went into the extinction and inattention, but the aphasia are also into the sensation, but the aphasia I didn't really talk about. So there are multiple different types of aphasia. Receptive aphasia means that you can't understand spoken language. Expressive aphasia is that, they don't really have coherent speech. It's very similar to what we see in our schizophrenic patients, that word salad type thing that they get. And then there's global aphasia, where they can't understand or express language. And then dysarthria, this is, um, with it's almost like they have like a heavy tongue. Their speech is very, very slurred rather than just fully incoherent. Um, and it just like their tongue almost sounds like too big for their mouth or too heavy for their mouth. Okay, so we're about to start getting into the more pharmacological stuff here, but make sure, again, we're monitoring therapeutic and for adverse effects. Medication adherence is going to be super duper important. Some medications, it takes a while for them to, build up into your system. If they are having some sort of neurological thing, you may have to put seizure precautions or fall risk precautions in place, or have extra equipment at the bedside, like suction or something like that to help out with those patients. You guys don't need to know. But just make sure, the one thing that I do want to note is that the medication called Haldol, aldopurinol, that one, um, sometimes, so yes, it's an antipsychotic, but sometimes we can give it on neuro units to just kind of almost like sedate a person. Like if they had meningitis, sometimes they get kind of antsy. And so we'll give them these medications. But one thing that you have to make sure that you note in this patient that's having this, is that they'll have those extrapyramidal symptoms. We've talked about them a little bit more, like a little bit in the past. Especially for the ANS, which we're about to go over after this. But make sure that you keep that in mind, that that is something that can also happen with this medication. We're trying to give it calm them down, but we could be making the problem worse. All right, so going into our autonomic nervous system, and then after this, all that's left is migraines. Um, so there's two big divisions of our autonomic nervous system. There's rest and digest, and then there's fight or flight. So we're expecting our fight or flight system. It uses norepinephrine. It's got, you know, two, well, it's got one, two, three, four, five different alpha and beta receptors. And then there's, those are broken up, or I guess overarching, there's two big primary receptors in the sympathetic nervous system, and then those are broken down with adrenergic having five, and then cholinergic also having some. Um, but here we're gonna see, an increase in blood pressure, an increase in heart rate. Um, think about, you're in, I don't know if you don't like scary movies, but if you're in a scary movie or something, that heart rate's gonna increase. It's doing that fight or flight. Or like, you know, just got out of your chest. Your heart's racing. You want to know how you did. You feel really stressed. Did I pass? That's your sympathetic nervous system kicking in. Versus your parasympathetic nervous system, you just got your grade back. You're doing a lot better. You can calm down now. All right, so here's just a little chart to kind of explain um, the parasympathetic and the sympathetic nervous system um, way more easily just with arrows and stuff like that. All right, so this is talking about the actual neurotransmitters that are involved. We have acetylcholine and norepinephrine. The sympathetic nervous system has norepinephrine. EpiPens are epinephrine. Take the hint. Um, and then the acetylcholine um, is the other one. I don't know if I said that or not. But here's what I was talking about when I was talking about those adrenergic receptors when we're breaking them down into alpha and beta. And this is kind of what they do and some examples of what an agonist is and then what an antagonist is. And then this is the breakdown of nicotinic and muscarinic. I can never say these, but think of the nicotinic kind of as like how nicotine works on your body. Um, and that might help if you're a vapor. And then fun fact, this atropine here, it's actually a derivative of something called nightshade. Um, and when it looks like a blueberry when you see it out in the wild. But when you eat it, it actually really, really increases your um heart rate and your blood pressure. It causes vasoconstriction, and we ended up figuring out how to modify it and using it in the healthcare settings, and we use it for like cardiac arrest and whatnot. Okay, so here's a little chart I made for you guys to kind of explain how they are kind of similar to each other, how the parasympathomimetics, the ones that mimic the system, work kind of like the sympatholytics. Obviously, they are going to work on different neurotransmitters, but they're very similar to each other and kind of the things that you expect, right? A sympathomimetic is going to help decrease our blood pressure, but so is a sympatholytic. And then here's a little bit of a mnemonic to kind of help with some examples of the medications, our common uses, as well as some very common side effects that we're going to see with these medications. Okay, so um, when we are talking about the ANS, um, there are some very common things that are going to be involved, like anaphylaxis. The most common treatment for that is going to be um, epinephrine because it helps open up those airways, right? Or like croup, same thing. We give them a nebulizer of epi to help open up their airways. Glaucoma, they have um, like hypertension in that eye space, right? So we are going to help decrease that. And we're going to use medications that are also used for controlling blood pressure. So anaphylaxis, it is a severe and life-threatening condition. That's when, someone has something that they're allergic to. Um, But make sure that your patient knows if someone is having anaphylaxis, just taking Benadryl is not going to be a substitute for getting epinephrine. And then when you do take epinephrine, make sure that you go to the hospital. For glaucoma, um, you know, beta blockers like propranolol are going to be very common for these. But the one thing that I want you guys to note is that there is, and it's not shown here, like in this photo, but there are two different types of glaucoma. One is gradual, it's very commonly seen in our diabetic patients, and then we have one that's actually going to be a medical emergency, and it's very, very painful. And if that is not rectified, your patient can go blind. Um, so and it's simply just because that intraocular pressure puts so much extra pressure on that optic nerve, just like regular glaucoma, that it leads to that blindness. Regular glaucoma can also lead to blindness, but they're going to start out, with normal kind of, it starts kind of like blurry vision, and then they'll get that peripheral vision is going to go away, and they'll get almost like tunnel vision. But again, that's more gradual, but they should be going to their eye doctor, especially if they're diabetic, and they should be monitoring that. Okay, so this autonomia, I'm going to talk some about these conditions because obviously they are from the dysregulation of the autonomic nervous system. POTS is one of the most common ones, and then there's vasovagal syncope, which, and if you've had me, you've heard me talk about this, vasovagal syncope, um, with rectal temperatures before. Okay, oops, sorry. Um, Again, this is that chart, but POTS, this is a postural orthostatic tachycardia. So when they are standing up really fast, they get very dizzy. These individuals need to have an increase of salt to kind of help regulate um, their nervous system. Because again, a lot of our nervous system is sodium potassium channels, right? So they're going to do that. It's going to regulate their nervous system and kind of also help bring up their blood pressure as well, because their blood pressure will drop. They get that orthostatic. Their blood pressure will drop when they stand up, and then as a consequence of that, they get that tachycardia and then they faint. Vasovagal syncope. So a lot of times it's that overactivation of the parasympathetic nervous system. Like if you are, some people get it when they're getting tattoos or when they are, I don't know. I've never really had it except for the one time where or if they're watching something new, like, you know, I watched a vaginal delivery and I got a little dizzy. So that's that vasovagal syncope. But also, in rectal temperatures, you have to be careful not to hit on that right side because it can trigger that vagus nerve and actually cause vasovagal syncope, which is super silly. Raynaud's, so they have a very cold distal extremities, but it will be extremely noticeable. So they'll actually have pallor in like a few of their fingers or cyanosis in some of their fingers or some of their toes. So certain fingers will just have an over-exaggerated vasoconstriction, and it'll be very, very cold. And then Guillain-Barré, they get random kind of like blood pressure swings where it's going to be really low or really, really high. That's Guillain-Barré. Okay, so Alzheimer's and myasthenia gravis. So I only put these two together because they are the one, they're not similar, right? They are similar in one way, but they're not. Myasthenia gravis is more of a well, it is a motor condition. Um, slash muscle strength condition versus Alzheimer's disease, it's like dementia, that progressive um, lack of memory and cognition. but both of them work on the acetylcholine um, receptors, and with the acetylcholine neurotransmitter. So in the case of myasthenia gravis, it's actually causing the destruction of specifically the nicotinic receptors versus Alzheimer's is just the overall progressive loss of the cholinergic neurons. And then there's some medications like Dizonapil, and then I'm not even gonna try to pronounce that, guys, but that one as well. And these are gonna help with these two conditions. Again, these are progressive, right? So, um, once we have a diagnosis, we can try to slow it down. But there's no real cure for these things, especially not myasthenia gravis. That's autoimmune destruction. So there's really no cure for it. We can slow it down, we just can't cure it. Okay. And the last section of this is going to be migraines. So, migraines. We have lots of meds to talk about with this one. So, migraines, it is a distinct throbbing pain. Someone will know when they have a migraine. So, the exact cause of a migraine is not fully known. It has been linked to like intracranial hypertension. It's also been linked to issues in the trigeminal area. So there's just a lot of kind of causes for it slash underlying mechanisms, but there's no really one pinpoint one. We also know that women are going to be at more higher risk for migraines. So there is probably a hormonal aspect to it as well. But it's going to be very different from like a tension headache. Yes, tension can cause or trigger a migraine, but they're going to feel very differently. And then that kind of uh, throbbing pain that they get is normally because of an increase of kind of blood flow to that area, like when you stub your toe and then your toe starts throbbing afterwards, the blood is rushing there, so it's causing that throbbing. Okay, so there's a unilateral migraine and then there's a cluster headache. So cluster headaches are normally kind of like around your eye versus a unilateral migraine is on one side of the head. So there's risk factors for it. Again, we talked about how women are more likely to experience them than men. Family history of migraines is also something that's super important to keep in mind. And then we have other things where we use diagnostic imaging like MRIs and CT scans to kind of rule out other diagnoses, like if someone had a neuroblastoma, that could potentially trigger a migraine because that tumor is putting pressure in a specific area. Um, so that extra pressure could cause migraines. Um, so I talked about that trigeminal vascular activation. So again, there's that vasodilation, that's that rush of blood, and that dilation is going to cause widening of your cerebral arteries. That widening is going to lead to that intracranial hypertension or a short, um, it doesn't really feel short because you have migraines for days, but increase in intracranial pressure. And just so you guys know, intracranial pressure, the index for a normal intracranial pressure is very low. Um, so, yes, you have some intracranial pressure, but overall, it's relatively low. I think the highest, like when you get to start getting into an unsafe range, is probably the better way to explain that, is going to be when your intracranial pressure is like 15. And then again, there's going to be some sort of chemical imbalance. Um, some of the medications that we're going to see, they work on specific pathways, like the serotonin pathway. And based on that, it's going to help decrease the migraine. There's also the trigeminal vascular area, so that trigeminal nerve it has kind of its own vascular system, and that's going to increase blood supply to kind of that area. Your trigeminal nerve has three branches, so for your eye, your cheek, and your jaw, and that can be the reason why someone has a full unilateral headache versus just a cluster headache. So these people are going to have photophobia and phonophobia. So light and noise are going to be very overwhelming, overstimulating for these people. Really, kind of any neuro thing where you have a risk of, that increase of intracranial pressure, whether it's temporary or a full intracranial pressure increase. Having them in kind of a darker room with less noise is going to be better to prevent overstimulation. And then some people, when they get migraines, they get really nauseous, or they start to vomit. So they may be put on antiemetics to help manage that. We talked about antiemetics in the GI lecture, so I'm not going to go over them, but make sure that you review that if you have not already. And then an aura. So auras happen with migraines and with seizures as well. So an aura just is some sort of predictive warning. Some people might see floaters. Some people might see flashing lights, or they stand up and they get almost like tunnel vision. Some people might smell burning toast. It's just something that can happen before they get a migraine attack that indicates one that is coming on. Not every single patient gets migraine auras, and then some medications are going to be for patients who have migraine auras versus some patients who don't get auras. So here are some things that are going to be common for migraines. MSG, I like my cup of ramen. I can't actually eat those anymore because I'm gluten-free now, but not by choice, by the way. No, I don't think anyone wants to be like willingly gluten-free. But MSG can increase someone's ability to have a migraine or to get migraines. Sometimes weather changes. It sounds really silly, right? But some individuals, based on the pressure of the environment, because when we do have more severe weather, the pressure outside in the air is going to change. That can also cause migraines. Stress, nursing school, if you have migraines, you're going to get triggered a lot because you have stress and anxiety and you have sleep deprivation. And then you're probably not eating very healthy foods because you just don't have any time. All right, so we've got a few medications that can help with the pain. So we have triptans. These are going to be our abortive medications. So they are taken at the onset of an attack, and it's to help kind of reduce it, right? We also have more preventative ones like the ergotamines, and then the regular pain relievers. Sometimes people can take anticonvulsants like gabapentin to help with their migraines. And then antiemetics are going to be just kind of for that nausea that people get. So vasoconstriction, I talked about how it's the, normally vasoconstriction is the constriction, the closing um, of the arteries, right? But one thing that you have to keep in mind, that these dilated veins, right, because of the medication that they're taking, it is going to be very important that if they have hypertension, that they're not going to be on L-triptan, sumatriptan, anything like that. Because these medications, since they do cause vasoconstriction, because normally when you have a migraine, it's dilating that vein, it's putting pressure on those walls, you have the vasoconstriction. Well, what is hypertension? it's the, you know, stimulation of the sympathetic nervous system normally. It also can be from like tumors and stuff on the adrenal gland, but your body's in fight or flight. So it's causing that vasoconstriction, and that's going to increase their blood pressure. So if they already have hypertension, putting them on a triptan isn't really going to help. It's actually probably going to make the problem worse and probably now make them a stroke risk or a heart attack risk or just anything heart risk. Other things that these serotonin agonists do um, is they block um, something called vasoactive peptides. And these are in the inflammatory process, but they're going to be triggered by nerves. And so that's going to cause inflammation, right? So by blocking them, they're not going to be able to release from the nerves. And then that's going to help, release or reduce inflammation. Um, and then, you know, the actual constriction of the nerves themselves, they're not the only thing that is increasing when we have a migraine. It's also because I said trigeminovascular, so trigeminal area and the vascular area, they're both increasing, they're both dilating. Um, and then it's also going to block pain, like an analgesic effect in the actual brainstem. So, um, ergotamines, they are vasoconstrictive. These are types of medications, by the way. They're vasoconstrictive. So they are also serotonin, work on the serotonin receptor. Um, but it's not really with um what's a good it's not really in the same process as like the triptans, right? They kind of work a little bit differently, even though they're both vasoconstrictive and both work on serotonin. Um, and they're also going to inhibit that peptide release. Um, they are, and I may have to correct this, but that they are given with, I'm assuming like Fioricet, which is one medication, Tylenol and caffeine in combination, to help cause that vasoconstriction. But I can double check that and make sure I'm not incorrect with that. That may have been something I put on my notes, and when I was typing up the PowerPoint, I may have forgot to refer back to see. I could have put a question mark next to it, and I apologize if I was. I'll put it in the description box if I was wrong. So triptans, ergotamines, again, different drug classes, but kind of work on the same pathway slash, not, but not really in the same way, if that makes sense. But the entire goal is to try to relieve migraines. So again, if they have any stroke disorders or vascular history, we shouldn't give them any triptans. Or if they, have any cardiovascular conditions or hepatic conditions, probably best to not give them this because it causes that vasoconstriction. This might sound silly, but also if they have like sickle cell disease, because we really want to prevent vasoconstriction in these patients. This is why we don't use ice on these patients. When they do have some sort of injury, we use heat to increase dilation of blood vessels. Because of the sickle cells, um, they would have a hard time passing through that narrow channel. So those are also going to be patients that are going to be contraindicated for these just because it increases kind of the risk of damage, hemolysis, stuff like that with sickle cell. So for migraines, it's important to kind of make sure that you time how long the migraine is. If you have a migraine that's been going on for a month, like go see a doctor. That's not a migraine anymore. But also don't take like your sumatriptan is not something that you take every single day. You're only going to take it when you have a migraine. And make sure you know about side effects. Any stroke-like symptoms, report them. Any cardiovascular symptoms, chest tightness, you feel like there's an elephant sitting in your chest, go to the hospital. And then, there's kind of another thing to keep in mind too is that you're going to get a migraine, you take the acute medication, you get temporary relief, and then you get a rebound headache. So sometimes individuals who have migraines, this medication can cause a paradoxical effect, and then lead to some sort of daily headache condition. So they have to make sure that if this is something that's happening and um, maybe they're taking their medication more often than they are supposed to, or um, it's it's just unrelenting even with the medication. They are going to have to go and make sure that they get treated because now they have maybe accidentally given them a little bit more of a complex um, migraine issue. Okay, well, that is all I have for you guys today. Okay, I think. Let me just double check. Yeah, that's all I have for you guys today. So I'm gonna double check on that ergotamines and make sure I'm giving you guys the correct information. I could have just put that on my notes, thinking about Fioricet, but I will let you guys know in the description box when I upload this video, so make sure you look down below the actual summary of what this video is, and I'll put it in edit and explain more information about that medication if I need to, and then my source will be there as well, where I got that information from for you guys. So if you have any confusion or maybe I didn't explain it very well in my edit, you can at least go read that source. All right, well, thank you so much, and a wonderful day, and I'll see you in the next one. Bye.